welcome to Leadership in Digital Health. In this episode, we're talking to Jeremy Petch on the topic of AI in digital healthcare, and in particular, explanatory AI. Now, I'll let Jeremy introduce himself in just a few moments, but the thing that really struck me in this conversation was the way in which the project was set up for success, and that was in the form of strong understanding of the data models that were necessary to achieve the objective, and that the objective was clearly defined from the outset, and that the clinicians were tightly involved and engaged in the process from beginning through to end. So without any more delays, let's start the conversation with Jeremy. Well, I'd like to welcome Jeremy Petch, who's here to talk to us today about AI and explanatory AI in particular. Hi, Jeremy. For our listeners, would you just like to introduce yourself and some of the things you've been working on?
Absolutely. So Jeremy Petch, I am a professor at the University of Toronto and McMaster University, and I'm the founder of the Centre for Data Science and Digital Health, which we just call CREATE, located at Hamilton Health Sciences, which is one of Canada's largest academic health science centres. And what we do at CREATE is really work with applied artificial intelligence, applied machine learning, and software engineering to try to improve the way that we deliver care. And all of the projects we do are in partnership with clinicians, where they bring their kind of clinical know-how and their ideas about how they want to be able to deliver care differently. And we bring a set of technical skills so that we can partner on projects to create kind of new technical solutions that will work for clinicians and for patients, fit into their workflows, and ultimately have an impact on patient care.
Wonderful. So can you tell me a little bit about one of the projects you've been working on recently? What did you set out to achieve? And what was the composition of the team that you brought to bear?
Yeah, absolutely. So one really great project that we've been working on is in partnership with our heart investigation unit. And one of the big challenges we face in Ontario, Canada, is a real overuse of invasive coronary angiogram, where we're doing tests on a lot of people. We're doing invasive tests, which are expensive and carry a small but real risk to patients, when we could be using non-invasive cardiac imaging to get many of those patients a diagnosis of non-significant CAD, coronary artery disease. And so what we set out to do was to partner with our cath lab to use their historical referral data to see if we could generate an AI model to actually help us screen effectively which patients should proceed directly for invasive coronary angiogram versus which should go for non-invasive imaging. And it turned out that by partnering together and really using their clinical domain knowledge and our AI skills, we were able to develop a model that can really accurately predict which test a patient should get. And we're looking just at our hospital at about $1 million of savings a year and 1 reduction in death per year. And when we're currently in conversation about scaling that to the whole province of Ontario, there's 20 heart investigation units spread across the province, and so those cost savings and those better patient outcomes potentially multiply quite significantly. So It was a great experience, and I think it was a good example for us of what can come when you get clinicians who really deeply understand the clinical problem, but are open to how they could use technology to help them deliver care kind of differently.
Yeah, that's tremendously exciting. What was the lay of the land, as it were, before your project team became involved? Where does the data come from to power the AI model? And what are the kinds of data points that you feed in?
Yeah, so basically the data that was available was coming from the referral forms, where community cardiologists were taking detailed medical histories and providing that referral data to the cath lab as they began to triage patients. And so where we were able to collaborate with the triage nurses to work ourselves right into that project. So as the data comes in through the referrals, the data is actually then inputted into the AI model. And along with the triaging of urgency, they get an AI recommendation about whether or not they should be potentially sending this patient on to cardiac CT versus directly to invasive angio. And that the upside of that process is just the ability to really integrate into the workflow really effectively. And what we found, what was really interesting about this model, was how much of the diverse data it was able to use. There was a lot of data about the clinical characteristics of these patients, of course, their age, their weight, their height, their medical history, all of that. But we were also able to link it to socioeconomic data. And so what we found was there was actually a lot of importance there as well. Important data, as we know, patients patients who are generally less well off have poorer outcomes. And those turned out to actually be very important in predictors in terms of the patient's risk of advanced CAD.
So did the referral pathways and the capture forms need to be re-engineered in particular to suit this project so that you're capturing the right kind of data for your purposes?
Right. Well, the good news was that the referral forms actually really contained the data that we needed because the community cardiologists had done such a good job of assembling a medical history as part of the referral process. But what we did need to re-engineer was actually the centralized triage model, because traditionally the expectation was that the referring physician would know whether or not to refer to cardiac CT or refer to invasive angiogram. And what we found was, in consultation with all the stakeholders, the most effective thing was actually to centralize the referral pathway for cardiac CT and invasive angio, and to actually have a single point of intake within our healthcare system for both of those cardiac workups. Not expect the community cardiologist to kind of guess which one they should be sending it to. And that was a neat collaboration because it brought together interventional cardiologists and radiologists in a common referral pathway, as opposed to sort of treating those as two completely separate entities. So that's really where the work had to go in, but ultimately really beneficial.
Okay, and so as the referrals come in, there's clerical staff that are working with those, and they're receiving real-time feedback on the suitability of which pathway to go down?
Yes, that's exactly right.
And so did that require a front-end integration with a kind of line of business clinical information system to integrate seamlessly there?
Yes, it absolutely did. So we're currently working towards more of a fully integrated tool. Our hospital recently transitioned over to Epic. When we started this project, we were still largely in a more legacy environment. And so with the AI tool currently exists as a standalone tool where the data is inputted through the electronic referral system. But we're currently working up an API so that we can integrate more seamlessly with the new HIS.
Yep. How significant a role did data standards play in the success of this project?
Oh, I would say that they were absolutely central. I mean, data standards, I'm sure your listeners will know, it's kind of AI is just like anything else, garbage in, garbage out. But one of the benefits of a system like Canada's, and I think Australia's as well, is that a lot of these services, like cardiac, have a provincial or sort of a territorial organization. And so there's a lot of data standardization within cardiac already happening. So common referral forms across the entire province. And those are actually, there's audits that occur through our provincial authority, which is called Core Health in Ontario. And so what that meant is that up front, we had really good quality of data, both to train on, but then also good quality data to actually feed the model in a production environment. But I think if you were just dealing with random data from an EHR, I would have been a lot more concerned. But we were able to sort of integrate this with a well-established process, and that made all the difference.
Can you tell us a little bit about how the data is fed into the AI? Does it need to be picked up and moved elsewhere into the cloud? Does it stay on premise? And how long does it take until the AI can start returning useful prompts?
Right. Well, that's an excellent question. I think in our case, because we were at a large academic health science center, we had a pretty mature research computing environment already. And so when my group formed, we added to that computing environment by bringing in a lot of GPU-based processing power. And so we actually have a pretty good sized on-premise machine learning cluster available to us. So that made our privacy people happy. This was all happening at a time when privacy offices were still a little bit more reluctant about the cloud, and so it was kind of a low barrier to entry for us to do things on premise. And that means within our team, we do need to have some sysops people who are really maintaining our machine learning cluster. But the upside is that, essentially, it's just down, the compute cluster is just down the hallway. And so from a deployment perspective, it certainly made it a lot easier. And then, and it is really happening in real time. As soon as the data hits the prediction engine, it's able to spit an answer out really in a couple of milliseconds. It's a very efficient model. It's not one of these large language models or something like that we're seeing with ChatGPT 4. This is more of an ensemble-based machine learning algorithm, so it's pretty quick to run on that kind of machine.
Does it require a prolonged period of training until it's useful?
Well, this is where it would really benefited to have that long-standing referral data. So we were able to train on 12 years of historical referral data that was captured through this provincial program. And what that meant was we had over 100,000 patients available for model training. And so, it definitely took about 4 or 5 months worth of close development between the cardiologists and our data scientists. So we really understood the problem, making sure that we weren't allowing for any leakage, important label leakage or things like that can really degrade the quality or build bias into a model. And we also spend a lot of time looking at fairness and equity concerns, right, which are a real major concern with the ability of AI to essentially encode racial bias or other things into it. So we spend a lot of time in that quality assurance process before actually going out and deploying the model in practice.
You used the term label leakage there. Could you describe for our listeners what that means?
Yeah, so one of the things that can be a real concern with this stuff is when data can get collected at different points, right? All care pathways are longitudinal, and data can be collected at different points in the care journey. But what can happen when you're doing retrospective data is you can sometimes sort of accidentally let something sneak in that was collected quite late in the care pathway and sneak in as a predictor. And so what that can mean is you've sort of given the AI the answer already without really realizing it. And so that the AI becomes really overfit and really overly optimistic performance results. And then you deploy the thing in the real world and it doesn't seem to work at all. And so you need to spend a lot of time understanding the care pathway and how the data is generated to make sure none of that occurs.
So the timing is critical in terms of when the information comes to light. You make it too easy for the AI, it doesn't get clever enough.
That's right. And then when you try and deploy it in the real world, you suddenly realize, well, that data is not available when we need it. And that's actually something that's important in increasingly becoming best practice in these predictive models, is really understanding the care pathway to say what data is available when the prediction is going to be made, and really excluding all the other data that's available to you retrospectively, even if that data would have really helped you get a slightly higher accuracy statistic, because when it comes to deployment, it's just not going to be there for you.
So let's turn to explanatory AI. What is that and why is it important?
Yeah, so a lot of these machine learning models, as you know, are black boxes. And what we mean by that is that, you can just treat them as sort of a system where there's inputs and there's outputs. And you don't worry too much about the system that's doing that translation of inputs to outputs. We could just call that a black box. And the trouble is, a lot of the really exciting machine learning models do function as these black boxes. Even if we can kind of understand the basic mathematics that are happening at a low level within those models, their scale and their complexity mean that we really can't understand why a specific model made a specific prediction. Or if, go back to the case we talked about, why did this model tell us that this patient should go directly for invasive coronary angiogram? We don't really know why the model did it. So explanatory AI is a relatively new area of research that's seeking to not make models interpretable, not to make it so that you can just look under the hood of an AI and figure out exactly what's going on, but to actually have the AI try and tell you what it was doing. In a not a dissimilar way to the way that a physician might explain their clinical reasoning to a patient. Even though the clinician might not explain every nuance of every paper that they've read and all the meta-analyses and everything, they'll simplify something for a patient and say, well, basically for a patient of your age and of your general health, then this is what we recommend. And we think that's sufficient for informed consent. The idea of explainable AI is it wants to do something similar. It wants to say, okay, yes, we did trillions of calculations behind the scenes, but really the reason we made this recommendation is because this patient had a positive stress test and they're over the age of 65 and they're male, and therefore we recommended they go directly for ICA. So that's kind of the hope of explanatory AI, is that we can, while not necessarily accounting for all the complexity of what's really happening within an artificial intelligence model, we can still understand, or we can still provide users with a good enough understanding of what was happening so that we can address this trust gap that so many clinicians have about AI, and try and increase the adoption of clinical AI.
So on screen, as someone is directing a patient into a particular angiogram pathway, the prompt is literally saying, saying, that this person of this background and age and this clinical profile are the reasons that we make this recommendation, and then it's up to the human to choose.
That's right.
What comes next.
That's right. That's very much the idea. And we have implemented that as part of that angiography tool, along with some other information that's important for clinicians to know, like the accuracy of the model, because the reality is, of course, no model is perfect, just like no clinician is perfect. And so it's important to be as transparent as possible with clinicians when it's the case that, the model is providing an output that really clashes with clinician judgment, because that's when this really becomes important. I think for most clinicians, if the AI is agreeing with them, they're more than happy to say, okay, well, that's a nice second opinion. But if they're seeing something really counterintuitive come out of the model, they want to be able to interrogate that before they make a decision. And that's where this explanation becomes so important.
Yeah. And as a final question, you introduced up front the benefits in terms of financial savings and suitability of ordering and indeed avoiding morbidity associated with investigations. What has the reception been like from the clinical staff, from the cardiology staff to this AI helping out?
Yeah, it's been really positive to date. I think because the cardiology group was really in the driver's seat, this never really felt like something that was being done to them, which is where I think a lot of technology projects can go awry. Rather, the technology, they really feel kind of empowered by this and are very excited because, of course, nobody likes to see a patient have a bad outcome on the table. And so the idea of being able to reduce that is extremely positive for everyone. And because we worked so closely with them to understand their workflows, we were able to implement this in a way that didn't add any work for anybody. And that was really critical because I think the reception would have been a lot more poor if we'd suddenly asked people to do a whole bunch of manual data entry or something like that to really make their lives more difficult, which is the last thing we want to do.
Yeah, and I think that is so integral to most digital healthcare initiatives today is, what's in this for me? How is this of net benefit to me rather than being a burden, whether I'm a clinician or a patient or in an administrative role?
Absolutely.
Wonderful. Well, look, that's been tremendously exciting to hear about. You've got an upcoming seminar tomorrow that you're hosting here at HIMSS, which I'm eagerly awaiting. Thank you very much for spending this time with me here today.
Oh, well, thanks so much for the invitation.
Thanks, Jeremy.
Great.